I just wanted to make a comment about something that's happening with monoclonal antibodies for the treatment of COVID. I don't know if you know this, but monoclonal antibody is basically an antibody that is cloned over and over and over again, targeted at a very specific disease state. Um, like rituximab is one that's commonly used against some forms of cancer and some immuno diseases. And basically, that antibody is targeted specifically at the CD50 receptor site on certain cells. It binds to that site, and basically, those cells aren't able to replicate. Antibodies, monoclonal antibodies, work the same way against COVID disease. They basically bind to COVID, specifically to the COVID spike protein, and they prevent it from getting into the human cells and replicating. And there's been some pretty promising results out of Israel. It seems like they're ahead of us in certain areas. But the way that the monoclonal antibodies work for COVID, these particular monoclonal antibodies work, is you administer the drug post exposure or at the latest, possibly during the first onset of symptoms. One of the more popular ones is the RegenCon, which is the casirivimab and imdivimab. Heck of a name, all these mabs. Anyway, Florida has been using them for quite a while with pretty decent results. I mean, if you look at the Florida data, they're not the worst COVID state, and they're certainly not the best COVID state. I happen to live in California. We've been really, really slow to use monoclonal antibodies, which is kind of surprising, really. We're doing better now with COVID than we did at the beginning. We made a lot of mistakes along the way. And it's like with any disease state, the more you see it, the longer it's out there, you tend to develop therapies and experience. Physicians get more experience treating disease. They see what works, they see what doesn't work, and they tend to move on. However, here in California, we're really, really not doing a great job of using the therapies that are available to us. I know we shun things like hydroxychloroquine and ivermectin, and honestly, I'm not quite sure why. There's a lot of potential treatments out there, and we're still learning what works and what doesn't work. So to say that, for example, ivermectin doesn't work, I think it's a little bit too early for that. It's going to take years before all of the data collected for COVID actually comes out. And with that said, the monoclonal antibodies seem to have some promise if given aggressively and early. And recently, the federal government decided that states can't buy monoclonal antibodies on their own. They actually have to go through the federal government now. The Department of Health and Human Services has basically started a process where they're sequestering the monoclonal antibodies and only handing them out to certain states. And to make sure that it's quote unquote fair, if you listen to some of the White House briefings, they want to make sure that everybody gets a chance, which to me seems kind of absurd because there are states out there that are using the monoclonal antibody therapy and seeing good results. I know DeSantis in Florida, he's been really, really pushing the early and aggressive treatment. And that seems to be working for his state, without the mask mandates, without the vaccine mandates. I think that's a valid approach. But like I said, here in California, we haven't been doing that. So now, unfortunately, it seems that it could potentially be a political agenda has potentially crept into how we distribute monoclonal antibodies, which is really quite sad. We'll have to keep an eye on that and see where it goes. However, I, for one, I think as pharmacists, I think monoclonal antibody is a great idea. And I think patients that have been exposed, people that roll into the ED, especially the high-risk folks, whether you're vaccinated or not, a monoclonal antibody could potentially work. And basically, you infuse the monoclonal antibody. In this case, it's a single dose. It's infused over, I believe, an hour. You have to watch the patient for an hour, but then in theory, your body will go to work. Those monoclonal antibodies will go bind to the spike protein, and in theory, the virus won't replicate. So if you end up getting a clinical version of COVID. It won't be as severe, or the symptoms will be extremely mild, or it may prevent hospitalization, or it may prevent death. So that's all I got for now, but be interesting to see where this goes. It's a real shame that all of this stuff has been politicized to this degree. I remember a time when physicians would throw anything and everything at new disease states, or new infections, or things they hadn't seen before. This may be the first time in my 20 plus years as a pharmacist where I've seen this happen, where I've seen the government actually take control of potentially life-saving therapies. And I do believe the monoclonal antibodies could be potentially life-saving. I believe using other therapies could potentially be life-saving. And I think by turning off the spigot for anything that's available out there would be a tragedy. I mean, you look at the Joe Rogan case that everybody had a conniption over. I don't know how old Rogan is. I'm not a big fan of Joe Rogan, but he got COVID. He felt like crap, whoever his physician was, and I'm sure it's because Rogan is famous and has a lot of money. He was able to get that individual to give him pretty much anything and everything he needed. And I think it worked out for him, and I think that's great. We could probably learn something from that. Anyway, that's all I have for now. Take care.